run into her, but I'll ask her if it's going to be early tomorrow as well, and I'll be here early in the morning. If that is the case, then I would do both of the last two lectures tomorrow, and then Friday will be of a review before your lunch. Okay. If I do have to separate those, then we are still going to do a review after the last lecture. So that will be done. Okay. All right, so today we're going to go over the hair and also of the nails. All of the things that we have already talked about in block 1 and then now in block 2, but this is just more ideal on the aspects related to these disease processes. Okay, so we're going to talk about all of these. So up top, it's talking about anatomy review. That is a part of the syllabus and what needs to be on here. But y'all have damn known this shit since freshman semester. So you're going to see me just go, okay? Then of the telogen alopecias, of the traction, yeah, it's all alopecias. And they're different, so you would see those. There's the beautiful stuff, boom. The terminal hair, we know that that is of the thick, of the pigmented hair, of the scalp, the beard, axilla, pubic region there. Of the vellus, short and fine. It's covering over much of the body except for all of the areas that are specific for the terminal hair, as we talked about over there. And then if you are a baby born, then you get lanugo, and then it's off and away it goes. Average scalp has 100K hairs. Some of them are even more than that, depending on the length and of the stuff if it's building up more, or if you're losing all of your hair, then you could have less. Stages, so the growing phase, that is when it's starting, then it goes in up to catagen, and telogen is of the resting phase and stuff. Like I said before, anatomy review, it's fast and gone, and I'm not going to test you on this stuff, I promise. Here's some of the clinical evaluation. So did it like right now, or has it just been over time? Are you having any systemic disease, high fevers, the psych stuff happening, the medications, examination, right? Is it just in one spot or is it all over? Is there scarring, inflammation, the plugging of skin disease in other areas? There's one thing called the hair pull test. We're going to talk about it next, but essentially it is just you using the fingers to pull their hair, and if it's 6 or less, then it's normal. If it's more than that, then no bueno. Yeah. You can also do some of the counts and of the testing. As I said, there we go. As far as it goes, one of the things if you're going to do the test is to not have that individual shampoo of the hair for 24 hours. Okay. Here's a giant chart that is just talking about the diagnosis, the breaking down. If you want to go through all of this, then you can have fun, yada yada. All right, so let's break it down right here, okay? So here's the telogen effluvium. So it's a diffuse loss. It gets worse every day. This could be lasting for 4 weeks. It's also of the thinning of it, right? So we're getting those of the outside big one, then it can start to thin. It's more common in of adults, but it can actually happen in any age. Most primary of the individuals who have this are females. Okay. Distribution, it's diffuse of the scalp, right? So it's not just gonna pick one spot, it's having some of the loss all over. Up and under that, the scalp looks good. So it's just like the hair wants to fly away. All right. So this will begin the 2 to 4 months after of an insult. So are they on some medications that could actually cause it to go away? Are they having a recent surgery? Are they symptomatic and having infectious process with some fevers and everything? Most important though, it's oftentimes seen of a postpartum female, right? So they've already had delivery. If it's their first child and they're losing their mind because they have to learn how to do all of the mother, then that could be causing it. Are they having some of the weight loss? So they're doing a crash diet, okay? That can be what's causing to have telogen effluvium, all right? So how do we diagnose that? So it could just be the clinical aspect. You're looking at it and it's generalized. You can see of a normal scalp that's not kicking it out. Some of the labs there, CBC, CMP, ferritin, and of the thyroid, okay? The difference of diagnosis, okay, so it's the antigen, which is opposite of telogen. Associated with loss of up to 90% of the hair. It can also be having that of the radiation, of the chemo, of the poisoning. So that's how that one is specific, whereas the telogen is just because of the stress, of the medications, of those things. So it's easy to see those things. Reassurance, become confident in the mother you are becoming and get it to go away because you will get your hair back. We can also do some of the cosmetic, and yes, we should get it back. Again, you can see in of the pictures here that of the scalp, it looks normal, okay? It's just sparse. You can see it right there over the one. That is not my brother with a mullet, because he always wears those things. Well, not wears those things, it's what he likes. But anyways, again, the scalp looks normal, okay? Now let's get into of the male, and I'm not going to point out any of the students in here who have all these things. I'm kidding. I'm not going to talk about my counseling. Anyways, we have all of the pictures and everything in here, which you can see, okay? So it's of the testosterone into the DHT and then act on the dermal papilla, okay? So it's just some of the shortening of successive of the antigen. In adolescence, you can see there it's increased size of the follicles. So as you get older, then it just starts to bear down. Okay. Family history of hair loss. If your dad had it, you're gonna get it too. Okay. Right about the 12 up to 40, then it starts to thin. And it can be going slow. We have the areas, right? So we have two of the types. So we have of the top in vertex, or we can also have of the sides. And so here is of the picture that is breaking them down, the difference, right? We can have it all up in front, we can have it in the back, we can see it on of the sides there with of the pictures. So how do we treat it? We will treat it with minoxidil, okay? Minoxidil. So that is topical stuff. It can also be oral, but usually more of the topical. Finasteride and the other ride, you can have some orals if it is, some things that are happening. If you are rich and you want to spend all the money, you can have transplants, especially if you're LeBron James. LeBron James, okay? Because he started off and he wasn't having it up there, and then now it looks beautiful. So, LeBron James. All right. So you can also do some of the flaps. You can have of the weed. You can have of the toupee to use those things. Again, here's of minoxidil. Minoxidil is it's first developed to treat of the hypertension, right? So we were having some of the balder men who were having of the hypertension, so we would prescribe them this, and then they would start to grow their hair back, and it's like, yay, what is this, So now I'm going to fix your hair, but I'm also going to help your hypertension and yada yada. It increases duration of the anagen, so it has those to be at rest and to grow. 2 to 5% of the strength stuff is of the over the counter that you could get at Walgreens, but y'all can prescribe it, and it's a little bit higher for it to be more sufficient. Ideal of a candidate is male if they are less than of the 30 years and that hair loss has been less than 5. If it works, and you should be starting to see it in about 8 to 12 months. Okay, so that is minoxidil. The other one is the rides, right? So it's conversion of testosterone into the DHT to slow down all of the hair loss, okay? Also marked, and it's used for Proscar, so they are just hooking up these men with some good medications that fix everything, right? I'm gonna fix your hair, I'm gonna fix your hypertension, your BPH, of this ride, and then also of the next one I'm going to talk about does of the same thing of the BPH, okay? We will see it start to happen in 3 months, and at that same time, once it's working, we're going to stay on it forever and ever, okay? So it's going to be treated. Yeah. Bottom there, sexual side effects, 4 to 5% during the first year of treatment. So we can prescribe you something else. Haha, that's funny. All right, again, this is of the other one, and it's just of a second choice. Okay, if the first one isn't working, then of course we could switch it up, but always going to start with which med? Minoxidil. Okay? There's some more of the pictures to which we talked about. It can be all of the frontal, all of the posterior aspect, all of the hair. It still looks thick, what's left, but we're starting to have disappearance there. Okay? We can also have this happen with some of the females, right? So we can see of it looking of the same, which is mostly all of the top, right? Because y'all grow of your hair out like on of the sides and everything, so that part stays there looking like that. So how do we fix this one? Oh, does it say the same thing? OTC minoxidil, okay, 2% or 5%, so that we can get this better. So back at the top, we can see that this commonly is the postmenopausal, okay? We're dropping, well, they are dropping the estrogens, and it's increasing the androgens. So this happens just like it does to males. Loss of the vertex, not as complete as the malar. There, if we need to check some of the labs, we can be checking their testosterone. We can be checking the DHEAS, and then the prolactin, and we always talk about the minoxidil. That is what theirs looks like. So it's most all up on top, like we're seeing here. All right, so that was all of the androgenetic aspects there. Now let's get into areata totalis and universalis alopecia. So alopecia is not just going to be in certain spots. It can move around, and you can see it in different areas, or you can see it all gone. But yeah. So areata, that is the partial loss of hair. Any area, and it can move around. Different than what we talked about earlier with effluvium, this one here is loss of the scalp palate. So the scalp could have some abnormalities as well, where of the other one, the scalp just looked perfect. If it is universalis, that's all over. So it can happen in the hair on the scalp, of the body. It could include some of the eyelashes of the brows to where it's gone. This part right here is very, very rare, where areata is usually one of the most common ones, which you all know because the Oscars on Sunday were good, but years ago it wasn't all that good, and it was because of alopecia, right? Slap Chris Rock. All right. So how is the presentation? So it's a sudden, an asymptomatic loss, round, sharply defined patches, exclamation point hair. So we can see peripheral hairs have the normal upper shaft and the narrow base. That the pattern right there, it presents as a band-like hair loss in the area. Okay, good. So how do we get it? It's unknown, right? Do we have some stress, which we were having with effluvium? Was there stress? So it could be in the differential diagnosis, family history, genetic factors. Have you seen this happen with of mom, of sister, dad and brothers and all that kind of stuff? Autoimmune, are you on, you've already had a kidney transplant, so you're on all of the autoimmune medications and that kind of stuff. Differential diagnosis, which I just said, effluvium, tricho, and then is this, some tinea. Treatment. If they are less than 10 years old, then we can do a topical steroid plus minoxidil, okay? If they are 10 plus years, then we can do some injections over there. So we can do the steroid there to get that in. And then also we're going to be using the same topical treatments. If it's over 50, if it's under or over of the 50%, then the topical, you can use some other thing to include systemic of the corticosteroids and prosthesis. The scalp here is of a breakdown, which is what we just talked about, okay? So it's more just getting into it. I always like for y'all to stick to these things, these beautiful things. The prognosis, okay? If it's small of the areas and it's the first one, it's probably going to get itself better. However, it'll be worse if it's all over the place. So you're having it in every aspect, which can also include the body hair. It can be the eyebrows. So yes, if we're doing it good, then we can see this improve in 1 to 3 months. So what's it look like? There is some of it right there. It's in one spot. It's not picking to a spot like we were having with the androgenetic of the males and of the females. So it's right there. It can happen in the multiple spots. So we can see the male up top that it's moved around, the other one there, the same thing. Here, it's losing in the spot, but there's some loss and some still there. So that's the alopecia areata. So it's in that. Another picture. Next is some of the eyebrows, which you can see happening here. You can also see this happen on the beard area. So we can see that spot that is just below the angular cheilitis aspect of the lips. Here, it's all over. Everywhere all over. So this is the entire scalp and eyebrows. Yeah. So that's that one. Up next is trichorrhea nodosa. Okay. Brittle hair due to overworking, weak points, nodes in the hair shaft. It can cause the permanent loss because it can cause some of the scarring. Okay. Treatments for this one must stop all hair treatments. Consider screening for hypothyroidism. It's not hyper, it's hypo. So this would be one of the things for us to back away and screen it for. So what does it look like? This is all of that, of a spot to where like it's breaking off. Of a better picture is that one right there, because you can see specifically where that's at, that it's breaking off. What's it look like in liveness? So you can see that spot right there to where, again, it's breaking it off, but it's still holding on to that shaft. Again, this one looks awesome. Again, it's not of the breakage that is down into the follicle, it's outside of it and it's breaking it. All right. Traction alopecia. So this is with our females. Regardless of race or ethnicity, this is all of the tight, all of the pulling, like all of our active duty females doing here is to braid up the hair or to tie it up or to have it where it's at. I've often wondered if this is part of the reason why the females are now allowed, to let it look how it is now. They could just let y'all have some more of that there, okay? Like I said, of the ponytails, it could also happen with the braids. It is of the fracture of the shaft due to of the traction. Okay. Follicle damage destroyed. And how do we treat it? Okay, we'll change your hair style. Let's just let it grow back because we're not pulling on it. So here's some pictures. You can see how that can work with the braids. Also here, some of the scarring of it too, just because of the pulls. Again, I'm not only talking about the females because some males do the same thing, right? The braids and the ponytails. All right. So this one is of folliculitis, which we talked about last block. So it's of the pustular eruption. It can cause some of the scars. Okay. This could be bacterial, and there's the most beautiful one right there that is around all over, staph. Clindamycin, y'all heard Mr. Booth say clindamycin like 1,000,000 times because that's what his favorite is. And this is what we would use specifically for folliculitis that is on the hair area. And that's what it looks like. So we can see some of the scarring because of the inflammation of the treatments and stuff that we would be using orally with the Clinda. Again, here is more of the cellulitis. So it's dissecting of the cellulitis, so it's inflammation that is increasing. It's very rare. We can see that the black males is one of those things that if it is seen, it's usually that ethnicity. Multiple inflammatory nodules on the crown, vertex, and occiput. So it's pretty much all over that it can do. It is boggy, fluctuant, oval, linear ridges that discharge purulent, foul-smelling material. This could also have these things of infectious process get into of the other areas, so it can spread into the sinus, fibrosis, and hypertrophic scarring. Is it painful? No. It could be, but it's nothing that a patient is asking for some pain medications or something, because it's just tearing them up. We will be treating them with the retinoids. So there's ISO, and this is how it looks. So we can see all of the inflammation that is in those areas, and it's all over. All right, so we just talked about all of the hair loss. Now let's talk to too much hair. So let's get into hirsutism. So it's in the area of the terminal hairs, right? In both of the females in a male pattern. So if you have a female who is looking like they're having some of the beard, if they're having it on the chest, it could be looking like that if it's of the females. Men are still just getting all of the extra hair at those same spots. But if it's hirsutism with a female, then it goes from there. Usually benign, it's all cosmetic, so you'll see one of the pictures that Mr. Booth put in here, and that looks very cosmetic. He'll laugh at you if you've already seen it. So high of the androgen levels, okay, this can be coming from the ovaries, adrenal glands, or it's just of an increase of the sensitivity. What are some of the possible of the causes? So more of the female stuff of the PCOS. It's most common. Those two things, right? So infertility, and then also what we're talking about right now. This can also be some endo, right? So we could have some Cushing. Have they been using more of some steroids in that area? Obesity is also there. True. Treatment-wise, it cannot be cured. It's just decreasing the amount of the hair that is out there. Okay. We can use some of the contraceptives. We could use some low dose the corticosteroids, spironolactone, Viniqua, laser, waxing, tweezing, plucking. These are all of the areas that are seen in here, right? So this is more so of the female of the locations, right? So we talked about how they can have it on the facial aspect, how we can have it on of the chest, of areolas. It could be more of the pubic area up to the umbilicus and stuff. So it's getting more and more. So there's some sideburns. There's the bearding aspects, which looks more like this, the older. I talked about the pubic area. So this is all of the vertical aspects. As you can see with the hirsutism, we're talking more so about the females. Some more. So with hirsutism, let's focus on the female aspects. Whereas if we get into the hypertrichosis, then it's more of the increase of the areas where there are some of the normal hairs that are just increased. Hyper. Excessive hair growth. The density of the lengths, and it could be, just an increase in those areas where the normal hair is at. Maybe localized, or it could be all over. So if they only have it on of their beard and mustache, okay. But if they're having it like from head to toe, ouch. Then it's like I went like this head to toe and the damn thing. All right, it can have all of the sides of the hairs, and it can be everywhere, but usually not on the palms and of the soles. So etiology is coming from genetic stuff. If it's a family and it has one, then if you only see that one, at home probably everyone has it, okay? You could be having some of this because of the minoxidil, which you use if it's balding, but you're using it just because you want more hair, or if you're using it 5 times a day just to have all of the hair grow back fast, and then it's just gonna blow it up. Malignancy can also cause it. So here's a younger individual who is having it all over. We can see here that this is more overseas areas that have genetic aspects. Could even be some of the younger ones. And I forgot that I took out the picture of a male who's like on his side, posed without a shirt, and it's all hair. Yeah, took it off. All right, so those are the things that we just talked about. So that is all of the hair, okay? So are there any questions as of right now for the hair stuff? All right. We can take a break or I can press on. Break?